Good morning. Brief review of the Professor, Peter O'Sullivan, specialist physiotherapist, and his association with another paper published through the assistance of Curtin University out there in Western Australia. Unsurprising findings. POS has been promoting that there is no specific technique benefit in bending and lifting, and again is published a paper that says it doesn't seem to make that much difference. So hot off the press, is lifting technique related to pain and functional limitation in people with lifting related back pain? Well, again, he still doesn't understand the difference between lifting technique and whether or not an individual is stable. Okay, if their lumbar motion segments are stable, then fundamentally you can lift any way you want and you will not have pain. But the key thing that he continues to mistake and miss and not understand: how do we maintain our stability so that we can lift any way we want and not get pain? And how do we get our patients to develop stability so that they can move their lumbar spine and not experience pain? Okay, we're talking about a joint here. We're talking about a complex joint that is necessarily moving through life. And if the joint is dysfunctional, it is going to be painful. So clearly the solutions to chronic low back pain revolve around improving the stability and improving the movement of the joint. And of course, the extra layer of management needs to be to address chronic pain pathoneurophysiology, which is a secondary issue. But if you get to patients very early, then there is you mitigate the development of those chronic pain pathophysiological processes, and then you're basically just having to fix a musculoskeletal movement disorder. But focusing primarily on the musculoskeletal elements, let's have a look at what POS is reporting. And there he's got a picture of his 5 participants. There were initially 6, but 1 pulled out. And he's just analysed all their movement kinematics with some still photographs. Okay, so still photographs as well don't really show movement quality. They're just a snapshot. But in essence, you can see some varieties of movement. They're bending over to pick up a object. And he also described that they changed the load of the object until the patient was satisfied that they could repetitively pick it up. So by changing the load and demand, you're already changing a variable that relates to stability. Load and demand is inversely related to stability, so that's a flaw in the study design. So you don't even need to have any load; you can just have body weight, and that's an assessment of bending and lifting body weight. So he's identified lots of different movement techniques and been unable to really find a correlation between any specific technique and less or more pain. The most significant misguided conclusion is this. Our study reveals that changes in lifting technique may relate to clinical improvements in people with lifting-related chronic low back pain on an individual basis, contrary to conventional clinical and ergonomic advice promoting safe squat lifting techniques. Our findings suggest that transition from squat-like towards semi-squat-like and stoop-like lifting techniques with faster lifting movements often corresponds with reductions in pain and functional limitation. These findings challenge pervasive recommendations for squat lifting and support an individualized multidimensional approach to managing people with lifting-related chronic low back pain. There's so many errors in that. It's not lifting-related chronic low back pain. The lifting may have created the development of symptoms, but it's the presence of instability that causes injury, then pain. And the goal of therapy is to restore stability. Once stability is regained, then the back pain disappears. Okay. If you then continue to move in a poor manner and develop further instability or relapsing instability, then you get pain again. So it's just so incredibly misguided to be focusing on lifting technique and making assumptions and correlations and inferences from lifting technique without understanding stability. And that is the biggest flaw over and over and over again with his research. And their intervention was 12 weeks of cognitive functional therapy. Okay, it doesn't have a focus on stability. It's a psychosocial centric intervention. Clinical implications. Our study found heterogeneous presentations of lifting techniques in people with lifting-related chronic low back pain, highlighting the need for individualised assessment and intervention strategies. Well, we all have femurs, pelvises, lumbar spines. There's not too much heterogeneity that defines biomechanically proficient lifting. Okay, when you lift a lot, you teach people to lift a lot and lift heavy and frequently, there is a very well defined way to most efficiently and effectively and safely lift heavy loads, large distances quickly. And that is part of functional movement. That is a definition of functional movement. We're not talking about artistic movement here. If you're talking about artistic movement, which is a completely different category of movement, move whatever way you want to achieve that artistic outcome. But if you're talking about functional movement, moving larger loads, long distances quickly, with multiple joints and multiple muscle groups, there is one biomechanically proficient way. So no, that is not right. It is not heterogeneous. There is one way to do it most effectively. Now, let's think about NeuroHab and what it's designed to do. We're improving and defining quality functional movement. All right, we define it very specifically. Neutral spine maintenance during torso inclination with hip-centric rotation and posterior kinetic chain activation. And why do we want to do that? Because we want to maintain the conditioning of the muscles that create stability to the lumbar motion segments. Okay, we transition patients from being unstable to stable through a defined movement proficiency approach, and hey presto, you get improvements in pain. And then we also define the clinical model of movement dysfunction in modern society and the development of instability, the development of injury, the development of chronic nociception and inflammation activation. No other organisation has a clinical model, a cause-based clinical model for low back pain symptoms. Okay, we define the disease of movement dysfunction that causes back pain. We treat the disease, the symptoms go away.